Hi, you found the way to the second part of this podcast on nephrology and Fabry disease. We're still at the Jan Ypperman Hospital in the city of Ypres. Two nephrologists engage in a dialogue with each other.
In part 1 of this podcast, we explained why it is important to include Fabry in the nephrologist's differential diagnosis. Now we would like to zoom in more on the screening process itself. So, Dr. De Schoenmakere, you had a few more questions about the added value of screening for Fabry disease.
Yes, indeed. Well, for starters, I would like to know how I should screen for Fabry disease and if there is a different approach in men and women. As we know, it's an X-linked disease. And are there parameters that we should take into account, like proteinuria, to start screening or renal insufficiency?
Well, in male, it is agreed that you can screen for Fabry disease when there is renal insufficiency or proteinuria. That's enough to do it. And in male, you can use the enzymatic test, the alpha-galactosidase A activity can be measured on a simple blood sample, can be a blood spot test. And this is a straightforward test which will make a diagnosis. If the enzyme activity is normal, you can exclude Fabry disease. If it is low or absent, you probably have to repeat this test because there's some laboratory irregularity always possible. And it is if low enzyme activity is confirmed, then you should confirm the diagnosis of Fabry disease with a genetic test. In female patients, we have to do a genetic test because as Fabry disease is an X-linked disease, there can be residual enzyme function. So enzyme function is not really a good test to make a diagnosis or to exclude the diagnosis. So there you always have to go for a GLA sequencing.
Yeah, and could you elaborate a little bit on that? You said that it's an X-linked and you have a partial activity of the enzyme. How does that go in female patients?
Well, in female embryos, there is an X-inactivation. So in every cell, there are two X chromosomes, but one of the two X chromosomes is being shut down. This is known as the lionization process. And depending on the way this is done during embryogenesis, this can be done in a skewed way towards the mutated X gene. Then you can have really a Fabry patient. So if most of the X chromosomes that are active are the X chromosomes with the mutated GLA gene, you will have a low alpha-galactosidase A activity. And depending on the organ, you can have diseased cells. So this is the reason why you have to do a genetic test in the female.
In a lot of patients that you are describing, like renal insufficiency and proteinuria, we would also perform a kidney biopsy. Could you compare a little bit the sensitivity and specificity of the AGAL testing, the genetic testing, and the kidney biopsy testing for the diagnosis of Fabry disease?
Yes, I think really the kidney biopsy can be looked at as a gold standard. Because if you do a kidney biopsy, you can see the deposits of GB3 in the podocytes. If you see that, then you can make the diagnosis as this is really a pathognomonic feature of Fabry disease. But of course, if you have an attenuated phenotype, it is possible that you miss these deposits or your pathologist, if he does not have good experience, or if the sample is somehow not optimal, you can miss them. But the biopsy is always of added value for the diagnosis.
We often use also like screening panels for genetic diseases in kidney disease. Is GLA mutations also part of these panels, or?
This depends on what panel you use, because all the labs they have their own panels for screening for kidney disease. And some panels, GLA is included, and in other labs, the GLA is not included. But I think it's useful to do that, to include it in all the gene panels. and to make sure that the coverage of the GLA gene is good, because using next generation sequencing makes it more easy to diagnose these diseases. In the past, we always have to check one gene, but nowadays I think indeed you have to use the panels. But then you have to check what is in the panels, of course. If you think on Fabry disease, you have to check if GLA is part of your panel.
Could you give us an idea of the price of these tests you are mentioning? And how is it done in practice? Do we take a blood sample? Do we do we send the patient to the lab, or how do we do it?
It's really easy. How do you do it? It's just a blood sample for genetics and for the enzyme tests. The lab will send it to the labs where they do the analysis. And it is not difficult to prepare the samples for DNA and for enzymatic testing. And concerning the cost for the patient, it is reimbursed. So they only have to pay a little part of it, and which means they pay about 8 euros in Belgium for the DNA test, and they pay about 8 euros for the enzymatic test.
Suppose I find a patient that has Fabry disease. How do I proceed then? Do I send him to a university hospital or an expert center?
Well, yes, I think you have to send them to a center with expertise. And expertise is always, in these cases, the expertise on the medical genetics is very important. So you should send them to a center with a medical genetics department, which are the university hospitals. But also, if you want your patient to be treated, they have to go to such a center with a metabolic department where they have to get reimbursement for treatment. But on the other hand, patients have to be followed by a multidisciplinary team, including a neurologist, nephrologists, cardiologists, pediatrician, if concerning children. So I think this can be done in your own hospital. But it should be interaction with experts on the disease, because it's really very rare disease, and it asks for specific follow-up.
And does everyone that is diagnosed have to be put on enzyme replacement therapy? Or is there another possibility like watchful waiting or other treatment modalities that are possible?
There's a lot of questions there. But first, concerning treatment, we have two sorts of treatments. The first treatment, indeed, is enzyme replacement treatment. Enzyme replacement treatment is a treatment with a protein that substitutes for the deficient enzyme. And this treatment has proven to diminish the GB3 deposits in the skin, but also in the kidney. And it has proven to have good clinical endpoints. So it diminishes the cardiac hypertrophy, and it can stabilize the kidney function if started at an early stage. There is another treatment, which is chaperone therapy. This is an oral treatment, which is given to the so-called amenable mutations, patients with specific mutations who have residual enzyme function, and this oral treatment stabilizes the alpha-galactosidase A activity. And you can give this treatment to a selection of patients. But indeed, not everybody has to be treated. Most male with classical Fabry disease will need enzyme replacement therapy to prevent organ damage. But some other patients, like many female patients, will not really need therapy, not specific therapy, but they can be followed in a conservative way.
When diagnosing a Fabry patient, I can imagine that there are some de novo mutations. next to patients that have family members who are involved in the disease. How do we approach that? Do you always screen extensively in the family of the patient?
Yeah, I think you have to do that. If you pick up a Fabry patient, it is very important to look in the family for other cases, as they can have a very large morbidity, and which is not understood by treating physicians. And we know from literature that on the average, we find 6 family members with Fabry disease if we find one index patient. So you should look in the family. And this is the work which should be done by the departments of medical genetics together with the treating physicians like the cardiologists and the nephrologists, because we have to talk with the people and we have to make sure that they understand what we are screening for. And also because making this diagnosis has a lot of consequences, also for family planning, for everything.
Well, based on this discussion, we have gained a better understanding on who and how nephrologists must screen for Fabry disease, but also how Fabry patients should be guided after diagnosis. Now, I have one last question for you, Dr. Terryn. Could you tell us about one patient case and more specifically about the patient journey and the diagnostic pathway?
Oh yes, I can tell you about the story of Mr. X, who is a male in his 40s. And we diagnosed him doing a screening study in a high-risk group. You have to know, about 15 years ago, I have done some screening studies in high-risk groups, amongst which dialysis patients, in transplant patients, and in patients with left ventricular hypertrophy, which are all high-risk groups where a lot of Fabry patients remain hidden. So we did this study in patients on dialysis, patients who were on dialysis without a good diagnosis. We had a lot of them. I think you know that too, Gert?
Indeed.
A lot of patients are on dialysis and nobody knows why. So we screened about 800 patients, and one of them was Mr. X. He was in his 40s and he was on dialysis, and he had been listed for a kidney transplant, and he had also had a stroke in his antecedents, and nobody knew why, but he had classical Fabry disease. And if we then next screened his brother, he also had symptoms. He had angina, his brother had also renal insufficiency, and he had hearing problems. So you see, this was really a very important thing to diagnose.
Indeed, I think the patient journey is extremely long sometimes because it's very insidious, and the symptoms per se always remain a little bit hidden because they resemble other diseases, and it can take years before you diagnose a patient like that, I think.
Okay, very interesting. Well, Dr. De Schoenmakere and Dr. Terryn, thank you so much for your cooperation on this podcast. Let's hope we have convinced your colleagues to be attentive to the symptoms of Fabry disease so that patients can be diagnosed and treated early. Thank you so much.
You're welcome. Thank you.
If you appreciated this podcast, watch out for the next one. In case you're interested in the other podcasts on rare diseases, you can also listen to the previous episodes with Professor Kassiman, head of the Metabolic Center, and Professor Robbins, cardiologist, both working at the University Hospital in Leuven. Thanks for listening, and who knows, until the next time.